Very much. Today, I am honored, humbled that you have given me this opportunity to give a keynote address, especially for our young surgeons. And the question is surgery a dying art? And I bring greetings from Sir Gangaram Hospital and Bhatia Global Hospital and Endosurgery Institute. First question which I would love to address here is surgery an art? Yes, it is an art. Why? Because we work in a place and that is called as a theater. So theaters, actors work. One. Second thing is, even if the surgeon is there, assistant is there, any and everyone is supported by the actors. What I mean, so it is never ever that one actor movie is there. So it is an art which is shared. The anesthetist is also an artist, the assistant is also an artist, and all of us are working in a theater, and that is why it has been the art and it will remain the art. Surgery, is surgery a dying art? Surgeon can die, but surgery cannot. So what I mean to say, my thoughts are that this was long time back, and it is a, I would say again, humbling to note that one of the surgeons was presenting from University of Wisconsin, and he also mentioned, and it gave us a lot of proud moment, that the origin of abdominal surgery was India only. And in Shushruta in 100 BC had written this book of Shushruta Samhita, and from there one can trace the origin of the surgery. And then similarly, the umbilical cord was tied with a suture. Again, it has been mentioned in our Vedas, maybe 1500 to 1000 BC. So that means the origin of the surgery is so early. Then how can it be that it is dying? So it will remain, but it will carry on changing. And surgery is an art which is requiring skill, precision, and care. As she had beautifully presented also, that surgeon should have the long fingers, definitely yes, excellent eyes, but a big heart, a compassionate heart, a warm heart, so that ultimately, honestly, I always tell my patients, if you have pain, I have more pain. As simple as that. So I should not cause any pain to you, and that should be out. And we have seen the progress of surgery in last so many years. You can appreciate in this classic photograph, the patient has been tied with the ropes, and then the surgery is being done. But obviously, with the advent of time, so many changes have occurred. Renaissance has occurred. The era of anesthesia. Honestly, I always feel that surgeons have progressed, surgery has progressed, but anesthetists have also progressed by leaps and bounds. Antisepsis, if it was not there, we could not have delivered this kind of results. Antibiotics. And the more you have done, more we have done, anatomy has also been learned right from the beginning. Many times, many surgeons, especially the surgeons who are elder than me, they always say triangle of doom. These are the new words which have been coined for laparoscopic hernia repair. No! So triangle of doom was also identified by Hazelbeck at that time, and then ultimately it was, so our thinking is that any day and every day all of us are unlearning, learning and relearning, and we are improving our surgical skills. And especially for my younger colleagues, I would urge them that please try not to become a skilled manual laborer. Try to become a cerebral laborer. This is a very, very small, important message, that carry on thinking. How can I improve? What can be the best method I can give it to the patient, so that ultimately the ultimate beneficiary is patient. There are surgeons who are always lagging behind, and there are surgeons who change with the changing times. So our thinking is, yes, all of us know. We used to, Dr. Madan, Dr. Jindal, all of us used to do truncal vagotomy and for the Vegas now also. But ultimately, where is it? For ulcer disease, where is it? So it has changed. So advances in surgery, advances will carry on, and non-invasive methods will carry on coming. And again, we used to do open cholecystectomy. Professor used to do open cholecystectomy. Whole of the team knew that 3 blood units have to be arranged before the cholecystectomy is done. And then all of us used to watch on this table how the cystic artery and cystic duct are being ligated with a suture. But we have seen the transition, and we are lucky enough that we have done the open surgery also, we have done laparoscopic surgery, we have seen the robotic surgery also, and we have been changing with the advancement of the technology also. Again and again, is surgeon going to die? No, never. Why? Because in emergency situation, open surgery has a place, and clinically, decision making is very, very important. And again, if we do not innovate ourselves, if we do not have the intuition also, then also, or if we are not able to take the split-second decision, that means we have not learned the art of surgery. And I am much impressed, especially to my younger colleagues, I would always urge that please do not learn this when to operate. All of us should learn when not to operate. And decisions are more important than incisions. That is very, very important. Not all situations need surgery, need intervention. And this is the situation one can see. The sun is setting, the new waves are coming. We can never ever say the sun will never rise again. Sun is going to rise again, sun will set again, the new waves will be there, and waves will be in the form of laparoscopic surgery, in the form of robotic surgery, in the form of minimal invasive or non-invasive techniques. Again, but thinking is loud and clear that this traditional surgery will never ever die. Only thing is that we have to carry on upgrading our skill set. And we have been lucky, I would put it this way, that we have seen version 1.0 of open surgery, 2.0 of laparoscopic surgery, 3.0 of robotic surgery, and today is the era, and especially again I am telling my younger colleagues, if you have not learned the artificial intelligence, today you will be doomed and patient will be doomed. So our thinking is, please do not rest on your laurels. You carry on thinking about improving your skill set. Today, for example, if I have to make a presentation also on such a different topic, I just go to Chat GPT, type, is surgery a dying art? And so many propositions come. And then I again ask, no, this is a lecture for the surgeons. Again, so many propositions come. So what I mean to say, please indulge yourself into the artificial intelligence. I'm not saying that lose your natural intelligence. No, not at all. But you indulge in artificial intelligence and ultimately make a difference. And today, all of us know, even the robots have come. The latest model of Da Vinci robotics has also come, that has included the artificial intelligence also. Means that when you are sitting on the console, you are able to see the MRI, you are able to see the CT scan, and you are able to correlate, yes, this is a cystic duct, artery, or whatsoever structure. So in last few years, in one decade only, one can see, yes, open surgery is declining down. The laparoscopic surgery has also plateaued, but robotic surgery is going up. I remember Dr. B.S. Rana, late Dr. B.S. Rana. He was my professor, head of the department in Maulana Azad Medical College, under whom I was trained. He used to tell us, "Kake, mera kaam te TOR karke chal gaye. Tusi agar laparoscopy nahi karoge, to toda kaam nahi chalna." And today, at this stage of life, I am saying, "Kako, kake ya kako ya kakiyo." साडा काम ते चल गया लेप्रोस्कोपी नाल, बट तोड़ा काम रोबोटिक के बगैर, आर्टिफिशियल इंटेलिजेंस के बगैर नहीं चलना. So our thinking is that please do not have that excuse cited. No, robot is not available. How can I go to Delhi? How can I go to US to get the robotic training? No, I think it is the mindset which has to be there, so that ultimately all of us have. This is, can you imagine, this is way back in 2007 when I did not have any access to robotic surgery, but still I went to Professor Giulinati for learning the robotic surgery. Then I went to IRCAD in France to Marseille, and after 12 years, when I met him in last month only in IRCAD, India, he was also surprised the way the decade has passed and the way all of us have progressed to do the robotic surgery for bariatric super morbid obese patients. Why should we not do the robotic surgery? Again and again, I am asking and inspiring my younger lot that today, for example, in 1 year, robotic 1600 installations of robot system have been there in 1 year throughout the world. Similarly, in India also, more than 150 Da Vinci systems are there. And if you make an excuse, or if you suffer from excusitis, that I cannot lay my hands on robotic and I should not learn, how I will be able to learn, I think you are suffering and you should not suffer. And so many surgeons have already been trained on Da Vinci system, so we should carry on unlearning, learning and relearning, and one should have that thirst of learning so much. For example, in this situation, the patient has had robotic sleeve gastrectomy, and after a few years, when he started having the weight regain, then also we could do the robotic conversion into a single anastomosis duodenal-ileostomy. As Dr. Somebody was mentioning about that Dr. Sharma was mentioning about that we should be afraid of duodenum. Yes, we should be. But only thing is, if the visualization is excellent, if you are able to do the suturing so well, if the magnification is beautiful, then you should not be bothered about that the patient will have duodenal leak. So our thinking is, yes, we have to unlearn, learn and relearn. We should be proficient with our manual suturing, the intracorporeal suturing, and the robot. Once you are sitting on the robot, it definitely helps you to do the suturing either on the roof or on the bottom, as if you are sitting inside the abdominal cavity. So thinking is, please carry on learning so that ultimately you do not have any excuses. And these kind of patients, yes, definitely we are able to give them the best only when we are having the robotic system. There will be challenges in robotic surgery, but please never ever believe the senior surgeons who say that there will be skill degradation. Not at all, never. So skill can never be degraded, skill can only be upgraded. And in the end, I would just give this statement which I have always been speaking about: a fool with a tool is still a fool. Means even if you are sitting on the console, even if you have the access of robotic surgery, but if you do not know your anatomy well, then a fool with a tool is still a fool. And for this, many surgeons, senior surgeons, blamed junior surgeons, young surgeons. They are not having the open surgery experience now. They are having virtual reality experience. They are simulating these on the robotics. So where shall they get the practice? No, our thinking is we should be ready to unlearn, learn and relearn, and we should definitely take the fullest advantage of AI also, and integration of artificial intelligence into the robotic system is here. It is here today. So we should make sure that we go into our theaters, modern theaters, which are having both the traditional skills as well as the technological proficiency. So in conclusion, I would just sum up by saying that surgery is not dying, it is evolving. Technological advancements augment surgical capabilities while the human element remains essential. Thank you very much. Please do not become the part of the robot. And I would just request your attention for a few seconds only. Do you want to become a modern crow? The old crow was throwing the pebbles into the matka. The new crow, laparoscopic way, but now you see this crow, it has become so intelligent that it can sit on the trap and quench the thirst and ultimately. So our answer is, please become the modern crow. Thank you very much. God bless you all.
Thank you, Dr. Bhatia. I will appreciate in choosing this topic. Recently, I inquired that whether this topic has been given to him or he has chosen. So you have, I think, yourself has taken this topic. You have selected this.
Yes.
But I will say certainly, our sage has seen three phases: open, laparoscopic, and robotic. But certainly the younger PG students who are passing out, they are well trained in laparoscopy, it's no doubt. But when it comes a problem in the theatre to open it, they are trembling. I have seen a surgeon trembling, how I will open. I have never done any open cholecystectomy. So, till you are in medical college, learn both, laparoscopic as well as open. Otherwise, in practice, there may come problem. No doubt, go for AI and go for robotic, that's an advancement. So, finally, I will say, surgery is not dying, it's improving, it's changing, it's having advancement. Thank you very much for this time.
Thank you, sir. Thank you. Just in a same note, I would ask especially my younger surgeons who are doing post-graduation, please see as many surgeons as possible. Whether they are the GI surgeons, whether they are urologists, whether they are gynecologists. So see them what to do and more importantly,
When
what
to do.
not to do.
And when to do.